nano sleeves, which are one step down in the range of sleeves displayed. The irrigation flow of dual microcoaxial on the right-hand side compared to a mono nano sleeve here, you can clearly see the superior irrigation volume. And page up. How is that achieved? The whole system only consists actually of one supplementary set of tubing connecting from the irrigating port of the handpiece, splitting the irrigation to both the handpiece itself and to an irrigating, also already existing handpiece, which can be adapted with a sleeve with a screw-on side port instrument of whatever style you prefer. In this video clip, you can see an example of such a procedure. Two sleeved instruments, normal side port instrument, in this case a fork, and the regular phaco handpiece as we are used to. In this case, with a very small incision, I was able to greatly increase the aspiration flow, almost double it. Personally, I think that one of the most important advantage could be the possibility to lower the bottle height from 70, maybe in the future, to 40 or 30, and possibly not have very high aspiration flow rates, but very low aspiration flows with very low bottle height, so actually reduce fluidics. But because of the closed system, as you here see, those air bubbles did not move at all. The turbulence is minimal in comparison to systems where you have actually leak flow. This is a feature which it shares with biaxial or bimanual phaco, which also is a more or less closed system. The one thing I would like to point out is that those two sleeves close off the incisions, I think, even better than with rigid metal cannulas. So in conclusion, this dual microcoaxial system offers us greatly enhanced fluidics, will offer us a system to have a very low turbulence system due to its closed characteristics. It's compatible with sub 2 millimeter ozil technology, and also very promising for dual microcoaxial aqualase technology. I thank you for your attention.
Thank you. Now I call from Germany Dr. Kurz to present biaxial versus coaxial phacoemulsfication in complicated cataract. Please.
Good afternoon, ladies and gentlemen. We've already heard a lot about biaxial phacoemulsfication, and I think this technique is becoming more and more popular among the cataract surgeons. In this prospective randomized study, we compared the clinical outcomes of conventional coaxial phacoemulsfication with a biaxial technique in eyes with complicated cataract. These eyes had more than a grade 3 cataract and additional pathologies like pseudoexfoliation, uveitis, anterior or posterior synarchia, phacodonesis, previous intraocular trauma, or prior intraocular surgery. We recruited 94 eyes of 94 patients for this study, either undergoing the biaxial technique or the conventional coaxial phacoemulsfication using pulse ultrasound. For the biaxial technique, we performed one-step incision of 1.5 millimeter in width. The phacoemulsfication handpiece had no sleeve, and the irrigation aspirations were separated. For the coaxial technique, 2.8 millimeter in width incision was performed in the two-step incision, and we needed 2 additional paracenteses. After phacoemulsification of the nucleus and irrigation aspiration of the cortex, microincision IOL was inserted into the capsular bag. It was the Acritec AcriSmart type 36A without enlarging of the incision. The primary endpoint of this study were the intra- and postoperative complications. Furthermore, we examined the best corrected visual acuity, the laser flare of the anterior chamber, intraoperative parameters like the effective phacoemulsification time and mean phacoemulsification power, as well as postoperatively the corneal endothelial cell count. The follow-up of the study was 8 weeks. Coming to the results, looking at the primary endpoint, we found no statistically significant differences in intra- and postoperative complications. For the biaxial technique, we found a complication rate intraoperatively of 23% versus 24% in the coaxial group. We had 4 cases of artificial iris defects, 2 cases of a sonular tear, and 2 cases of an optic crack of the peripheral IOL during implantation of the lens. In the coaxial group, we also had 4 cases of iris defects. We had 1 eye with a sonular tear. We had 1 case of a posterior capsule rupture with anterior vitrectomy, 1 case of an anterior capsule tear, and 1 case of corneal endothelium opacification during the phaco maneuver. Also in this group, we found 1 case of an optic crack during implantation of the IOL. Postoperatively, as I said before, we have found no statistically significant differences between the groups. Corneal edema was found most often in 40% in the biaxial group versus 35% in the coaxial group at day 1 postoperatively, which diminished during the first postoperative week. We found pupillary distortion with 3% in the biaxial group versus 7% in the coaxial group. And we had cases of fibrin exudation, which was about 3% in each group. We found statistically significant differences in the intraoperative parameters. The effective phacoemulsification time was statistically significantly lower in the biaxial group with 1.3 seconds versus 5.4 seconds in the coaxial group. Also, the mean phacoemulsification power was statistically significantly lower in the biaxial group with 3.3% compared to the coaxial group with 12.9%. Regarding the other clinical parameters, we found no differences in the best corrected visual acuity, in the laser flare of the anterior chamber, and in the corneal endothelial cell count. So, in conclusion, at our primary endpoint, we couldn't find any differences in the intra- and postoperative complications between the biaxial and coaxial technique in eyes with complicated cataract. Regarding at the biaxial phacoemulsfication, this technique showed a lower effective phacoemulsfication time and a lower mean phacoemulsfication power. These results could be explained by a better grooving of the phacoemulsfication handpiece into the nucleus during the phaco maneuver. We think that a microincision through an incision size less than 2 mm will be the future, either with the biaxial or the coaxial technique. Thank you very much for your attention.
Thank you. Now I call the chair from India to talk about evaluation of intraoperative performance and postoperative outcome following microcoaxial phacoemulsfication and